On behalf of the UBC Faculty of Medicine and the Division of Sports Medicine, welcome to the 12th Annual Chan Gunn Lecture. My name is Michael Cole. I'm the Director of Sport and Exercise Medicine at UBC and the Chair of the Dean's Advisory Committee on IMS. The Chan Gunn Lecture is an annual public lecture where we share information about the Gunn IMS model and Dr. Gunn's approach to the management of persistent myofascial pain. Dr. Chan Gunn is without a doubt a pioneer in this field, and the Division of Sports Medicine is privileged to have the opportunity to work together to continue to build the world's leading center for IMS research and training. Dr. Gunn received his bachelor's, his master's, and medical degrees from Cambridge University. Dr. Gunn and his wife immigrated to Canada in 1966, where he joined the Workers' Compensation Board in Vancouver as a staff physician. In that position, he began to explore the nature of chronic non-injury pain, and after years of research, developed a new approach to relieving it, the Gunn IMS model. And thanks to Dr. Gunn's commitment, UBC is home to an IMS training program, an IMS research fund for graduate and undergraduate students, and this annual lecture. So before we start, I'd like to begin by acknowledging the Indigenous peoples of all the lands that we are situated on today. And while we're meeting on a virtual platform, I would like to take a moment to acknowledge the importance of the lands that we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. And we're very pleased today to have Cory Choma. Cory has been teaching Gunn IMS since 2003, instructing over 1,000 students to be safe and effective at intramuscular stimulation. He's co-authored the chapter on Gunn IMS with Dr. Steve Goodman in the textbook called Trigger Point Dry Needling by Domerholt and Fernandez de las Peñas. He's a practicing physiotherapist whose practice includes chronic muscular athletic injuries and the treatment of persistent neuropathic conditions. He holds a clinical specialization in pain science through the Canadian Physiotherapy Association. And most recently, Cory has created the Pain Made Easy certification program, which provides clinicians a simple to implement framework for taking persistent pain clients through the stages of recovery.
Thank you very much, Mike. I appreciate it, and I appreciate the opportunity to speak at this annual Chan Gunn lecture again. My topic, as you can see on the screen, is treating the periphery old school? Bridging the gap between peripheral treatments and modern pain science. So let's head into the learning objectives for my talk today. So I want to identify and highlight some unique models that fall under the description of chronic pain treatment or pain management clinics. We always see these terms in our clinical practice, but I'm going to highlight a little bit about what they may mean because they don't always mean the same thing. The second thing is to present kind of the treatment option that I used, which seamlessly blends 4 to 5 different kind of models of care within one linear treatment plan, as opposed to having them all act independently and individually. I also want everybody to understand the clinical goals of treatment and its plan in this particular case. And what I mean by that is some kind of treatment plans would have the goal of pain relief, and other treatment plans are more kind of rehabilitative or functionally based, where for me, functional improvements precede pain relief, and this precedes or is more important than finding a smoking gun. Whereas in interventional radiology, it might be exactly the opposite. They're both equally correct, but they are different, and we should understand that. And then the fourth thing is that I want to highlight that, of course, what we're supposed to be doing is working together for the protection and advancement of our patients. This is our most important goal, and we need to be client-centered instead of being diagnosis-centered. So I have a question. What do you think of when you hear the label chronic pain treatment? It means different things to different people. Different and unique treatments can and often should be utilized in one client simultaneously. But in order to do this, you have to have a very well-defined and conceptualized set of goals and progressions, and it has to be done within a unified care plan. I always say to my clients that goals drive behavior. And it's not always as simple as simply pain relief. That's a component of it, but oftentimes if we focus on pain relief only, it ends up being somewhat frivolous and incomplete. Chronic pain treatment in this case study utilizes traditional pain science education and skill acquisition, along with Gunn IMS needling, and it does so in absolute harmony. Getting rid of peripheral nociceptive inputs can be effective, influencing the central nervous system via the peripheral nervous system can also be of interest and effect. Additionally, education, pacing, grading, and return to function are all very important. But can they work together? Is there more to consider? Well, in my humble opinion, the answer is yes. We have to coordinate our efforts, each one using contributions that we have to serve and advance the client on their specific journey. We can do this by understanding how and where our specific treatment fits within the biopsychosocial framework and how to present this to our client using pain science terminology. It's not that hard, so let me explain. Let's elaborate on my subtitle first, the subtitle being Treating the Periphery as Old School. And I want to highlight this by remembering that we have these divisions, the peripheral tissue, the peripheral nervous system, and the central nervous system. So as you can see on the left, medicine started with natural methods of healing. We added naturally occurring herbs, and through modern medicine, represented by the stethoscope, and technology, we have progressed to highly refined single molecules that have potent physiologic responses. Our progress has enabled us to use some of these chemicals and technologies to ablate some of the causes of pain. In doing so, though, we run the risk of causing more harm than we resolve, and at times missing the point. Kind of another double meaning, right? That, though, brought me to a 2015 chronic pain course looking for more conservative answers instead of just ablating the pain source. At the end of the second day of the course, this comment, Treating the Periphery as Old School, was shown on a slide. I objected and added that if we were to say treating only the periphery as old school, it would be kind of less inflammatory and less abrasive, being that the room was full of peripherally guided physical therapists. So as you can imagine, a mild argument ensued, and from this I now understand that there does appear to be a war or divide of types in the pain world. Perhaps this war is based on real estate, as wars often are, with the real estate being defined by peripheral tissues, the peripheral nervous system, and the central nervous system. The instructor and I never did see eye to eye, and I found out a year later from some physical therapists in the Canadian Physical Therapy Association that there was still ongoing talk of this semi-argument that we had in this course. So let's talk about the referral that came to my practice. The referral came to my clinic from a gentleman named Dr. Barry Jelena. He's a very interesting man whose job, it seems to be, is to assess chronic non-recovering clients and to somehow case manage a coordinated care plan, even though he works completely outside of any specific clinic. In this case, he was working for a litigating attorney, and that is part of the interesting part, how this referral came to be. The purpose of the referral, as it stated, was chronic pain management in a facility with a rehabilitative focus. This goes back to my discussion of different types of care plans. The care plan at my facility is a rehabilitation care plan. So that is to say that it provides a kind of a pain relief aimed at function that subordinates but is also interested in pain relief. But really it's the return to function that we're primarily concerned with. The chronic pain management plan of this MedLegal report called for treatment including a chronic pain physical therapy program, and the initial direction included Gunn IMS named specifically and in quotes, if applicable. It also stated that if the client experiences a failure in this treatment plan, which was conservative, consideration might be given to a radio frequency ablation procedure, or RFA. Within the medical legal injury management report, important notes that help kind of define the nuances and timing with this case are listed here on the slide. So in October of 2017, there was the assessment at my facility with a chronic pain physio. Later on, about 10 days later, there was a medial branch block to the left C4-5 facet joint. And approximately a month after that, there was a repeat medial branch block to the left C4-5, also adding C5-6. So as you can see, what we would like as a linear plan is kind of a coordinated plan with multiple balls in the air. So the route here was a medical legal opinion and caused the referral for interventional radiology, called a pain management clinic, with a primary goal of pain relief. There was also a referral to a physical therapy chronic pain program where the primary goal was return to function and autonomy with an additional goal of pain reduction. So who is the lady? The lady was a 70-year-old female, retired, married, living independently with her husband in their house. She had a motor vehicle accident in December of 2016, and prior to being assessed by me, she had past treatments that included chiropractic care, a lengthy course of physical therapy without symptom resolution, acupuncture, medical management including Percocet and x-rays, and peripheral cortisone treatments to her knees for OA, which was flared up by the accident but not caused by it, and relevant for reasons that you'll see in the next coming slides. Her initial assessment with me again was in October of 2017, and I wanted to point out that the interventions presented here occurred 11 months post-MVA. So from my point of view as a kind of well-aligned medical management system, we were woefully late by coming to her 11 months later after her MVA. So let's talk about the players involved here. There was a lawyer, there was an insurer, a physician, and the client that were all at play prior to my assessment. So I guess I want to point out from that point of view that what used to be kind of a covenant between physician and patient is now more complex as funders and lawyers may each influence patient care. What makes medical management much more nuanced is that we all have to get along because we're all acting at the same time. We also live in a time where the patients are increasingly influential with both positive and negative consequences. I'm sure all the prescribing physicians in the room can appreciate that. Our system is simply not set up to promote communication between practitioners and other influencers in a mandatorily coordinated way. This is being addressed in part by multidisciplinary pain centers. I've observed that over the last 15 years, these centers are often truly multidisciplinary as compared, similarly compared to well-functioning set of medical rounds that I've observed and participated in the hospital. However, this was not the case for our client prior to her consultation with Dr. Jelena. Each influencer had their specific goal, and they were clearly influenced by funders. Advancement of the client case was generally not well served, and the use of multiple but non-coordinated disciplines seemed to be the order of the day. The client was obviously very self-interested, and she was the person that requested physio, chiropractic, acupuncture, and cortisone injections. The physician was obviously concerned with the client, and in particular relief of pain, and finding a smoking gun, so they had a referral to radiology. The insurer had commissioned an independent orthopedic examination, and the lawyer commissioned a medical legal injury management report. That's where I got my referral from. So it was interesting for me to note from the client history that most treatments appeared to be influenced primarily by the client, and this was also stated in the independent orthopedic exam. What Dr. Jelena was able to do was to coordinate all involved subordinate to his plan, and then to take on new people, and in my opinion, the case worked quite well, which is why we're presenting it here today. So let's move on to the chief complaints for this client. The client presented to my office with pain in the neck and the upper thoracic spine, left shoulder pain with occasional numbness, headaches 3 times per day lasting approximately an hour, requiring medication and control. She was no longer doing volunteer work, and she was unable to play with her grandchildren that were aged 11, 14, 19, and 24. She also complained of poor sleep quality. She went to bed at around 2 a.m. and stayed in bed until 9 a.m. And her comment, in summary, was, "Every time I move, I hurt." She had estimated her pain reports at best were a 6 out of 10, and at worst were rated as a 10 out of 10. And her goal, when I asked her what her goals for care was, she just wanted to do more exercise. She didn't say pain relief right away. She didn't comment about, in particular, about activities of daily living. She just wanted to exercise more. So I found that very interesting. And then I've listed on the side here aggravating factors and easing factors because, again, I think it adds a little bit of nuance to this case. So for aggravating factors, she stated that most things hurt. Sitting had a tolerance of about 15 minutes. Stretching seemed to hurt. Activities of daily living like sweeping, ironing, driving, shoulder checking, and much, much more, according to her, also hurt. So the takeaway for me is that this was a very broad restriction, as opposed to a single entity, single smoking gun piece of tissue. Now, on the side of easing factors, she says, well, it's okay if I do nothing. Rest can help a little bit. Heat helps if I use a neck bag. Painkillers help. And the diagnostic block which she had was temporary. And my take home from that is that everything she was relying on was passive. None of it was active. And that starts to influence what I think is going to be important with the education and the kind of trajectory of care, which I'm going to go through in a slide coming up. So, the treatment history. Starting on the 31st of August, she had some radiology that we were concerned with. She had a cervical spine plain film, which highlighted the C4-5 and C5-6 degenerative changes. She had the medial branch block in October and again in November, which I commented on. And as you can see in the imaging below, this is an image of her neck. The little black dot represents where the blocks were done. And the blocks in this case were done with the idea of a potential RFA. And so what the take home is from this is that both of the blocks gave her very significant relief in her pain, which lasted for approximately the half-life of the medication used. And this is considered a positive for going on to an RFA. The RFA, of course, is a burning of that nerve root with the hope of reproducing the decreased pain that was experienced during the block. So when we're going to do an aggressive procedure like burning a nerve, we have to balance risk and gain. Keep in mind that the medial branch blocks and the conservative care I was providing were occurring at the same time. When we're looking at the blocks, the risks for a medial branch blocks would be worsening pain, burning, anesthesia, and decreasing selection and allodynia. Kind of more serious effects would be neurologic dysfunction, including motor deficit, sensory loss, and differentiation pain. Also listed is spinal cord fraction, which can occur resulting in quadriplegia and Brown-Séquard syndrome. And others that were also listed were dizziness, ataxia, Paradis, post-procedural infection, and vasovagal syncope. So what I would want to take away from this is, of course, when we're doing things for client, we're taking into consideration all the risks. The adverse effects of the interventions that I was using with modern pain science and education would be almost nothing, but never nothing, right? Miseducation can always take a client down the wrong path. Gunn IMS has its, although it is a non-cutting needle, and has not had any demonstration on imaging of showing things like scar tissue from repeated needling. And of course, in our course, we talk about things similar to a slight worsening pain or the possibility of post-procedural soreness and bruising and other things like this. So we have to balance the two. And as you can see by the slide, we think of going on to burn the nerve root as being a higher order of potential damage, and so we would choose that secondary to the conclusion of the more conservative care. And that's what we did in this case. So here's the care plan. It was a progression of kind of being where the client is, thinking about pain relief, but also function, giving the client a level of control and a return to the lost components of their life. On the left side, we have the central nervous system, which includes both the processing of their pain and the implications for the behavior that they choose. And on the other side, we have the peripheral nervous system, where a lot of the impulses are that would be kind of gathered by the central nervous system and processed in order to inform the client if they were in pain or if they were engaged in pain relief. So too often, the world outside of a well-functioning multidisciplinary clinic views the interventions for pain or for chronic pain as individual pieces. And I think that this is a bit of a loss. These primarily peripheral treatments often appear at odds with a modern pain science approach to recovery. And I often hear things like, as you saw on the slide, peripheral treatments are old school, identifying maladaptive thoughts and behaviors are where we have to go. Pain is an output of the brain, which is of course true. But it's taken to mean that we have to therefore address the brain as the only method of resolving pain, which I'm posing today is incorrect. And that we have to constantly look at things like grief, anxiety, depression, addiction, hopelessness, helplessness, and many, many things more if we hope to give the client a positive outcome. I think that those things benefit, but it's not always true that we have to do that. So I ask you, where is the client? What are the client's goals? Do they include pain relief? Do they include an increase in function? Do they include an increase in control of her life? And a return to the lost components of her life? And that's where it is for this client. I kind of think that too often in the private practices outside of these multidisciplinary pain clinics, we've become too microscopic in our analysis of procedural effect, our kind of route of chasing pain, looking at pain-related behaviors, or always finding a key cause to pain, like a singular key cause. I think that we've become so microscopic that we've once again lost sight of the client that has just merely a singular nervous system. Our client doesn't have three components to their nervous system, they have a singular nervous system. So if we look at them as a whole instead of individual components, we'll see that we have a potential for a progression of education leading to Gunn IMS, leading to a return of function. As you can see on my slide, with the education, we're taking the person from a highly sensitized hyperarousal state, shown in red, and as we educate them for simple things like hurt versus harm and the use of exercise and sleep and circadian rhythms, that there's a general decrease in that hyperarousal. As that hyperarousal has taken foot, we can then add things like Gunn IMS that will now act in the same way on the peripheral nervous system to decrease that hyperarousal state that the education and guidance does on the central nervous system. As the Gunn IMS increases in its role and being effective by decreasing hypersensitivity of the peripheral nervous system, again, a source of information for the central nervous system, then we can slowly increase the functional contribution of exercise and return to ADL that the clients want. When we do that first, in the presence of a hypersensitized nervous system, we run the risk, of course, of just adding more arousal to an already hyperaroused system. So in the case of this particular client, the initial care was heavily relied on information from a chronic pain program called the Pain Truth and another chronic pain program called Pain Made Easy. And each of these added a certain amount of neurophysiology education and skill development. As psychosocial factors influencing the nervous system, hypersensitivity did increase. As a result, Gunn IMS was able to be increased. Gunn IMS aimed to diminish the nervous system hypersensitivity as well, although with a different mechanism targeting the peripheral nervous system in its application, but of course impacting the central nervous system as well. As the overall tissue sensitivity and emotional or behavioral sensitivity normalized, reliance or influence is then transferred to the client activity program, which is intended to be self-monitoring and self-regulated. So moving through the plan. In the Gunn IMS model, we talk about partial denervation supersensitivity. And in the Gunn model, we look for 8 features of pain that could be of neuropathic origin. I won't read them all because we've all looked at this quite a few times, but I will highlight a couple. So a delay in onset after precipitating injury, well, I've seen this person on the 11th month, so that's obviously going on. The presence of abnormal or unpleasant sensations, well, we've seen that when she rates her pain a 10 out of 10. We look at her shooting or stabbing pain, her paroxysmal pain, that was there. Her allodynia was present in her every day. Remember, she said all things hurt. And then even something like pronounced summation and after reaction. The more exercise that she did, the more pain she felt. So these are all things that we're going to look at within the Gunn IMS model, and pretty much all of them were present in this case. So with a solid therapeutic alliance with this client developing through the education turning fear into action, it became obvious to me very, very early in the case that the Gunn IMS model would be trialed and was appropriate as early as, I think our trial was on treatment 2 or 3. This is a slide that talks about the Pain Truth construct that we used. The initial plan required kind of a method of education to create a positive and proactive environment for the client. The mindset is essential for improving things like pain, severity, anxiety, catastrophization, kinesiophobia, depression, and rumination, and much, much more. So our first visits comprised of educational components from both of these kind of pain programs. This one is the Pain Truth program, and as we move forward, there were some client feedback sheets and education sheets that we call Pain Made Easy. There was in particular 5 of them. The first one was just is called the Department of Veterans Affairs Pain Rating System, or the DVPRS. It provided a common language. With a common language that made the client feel heard, we were able to discourage catastrophization, which I think was made clear in her case by a pain rating of 10 out of 10, giving the presentation that she had at my clinic, which was visually a very normal functioning lady. You would not have expected a 10 out of 10 pain from her. We went on to give her sheet number 2, which kind of reminds her that her physiology system is working well. That's the opposite of what catastrophization will tell you. And it helps create a very obvious plan forward. Although you feel like SpongeBob, you want to start encouraging looking like a regular muscle with regular function, and the details of this plan go through specifically how to achieve that. The next sheet was a set of the symptoms that she had specifically put into a hierarchy so that she could observe the lower numbers 1, 2, and 3, which are symptoms that are of a lesser impact to the central nervous system, like lost range of motion, feeling of tension, or proprioceptive loss. And it differentiates those from dull pain, sharp pain, and numbness, which are higher order symptoms that lead to catastrophization. So we wanted her to know what the early signs were so that she could then act on them earlier rather than waiting until they hit sharp pain and running into taking a pain medication. The next one was explaining why do I hurt at rest and when I move, and what can I do about it. So this is an easy visual that emphasizes the point made within the Gunn IMS course that we must stay away from overloading the nervous system. And what this one shows you that on the far left, if you do nothing for too long, you will hurt. On the far right, if you overload the tissue, you will hurt. And with that white slice of pie in the middle, there is a part that we can all agree on where it hurts less, and we want you to spend more time there. The final slide we call the 50-10 rule, and it provides the client with a very, very simplistic rule so that they at least know what to do and helps them define rules of engagement. And on the bottom of the sheet, it allows us to gather specific client information on what the functional losses are. This is helping us refocus them from only a pain complaint to also consideration of function. And on the right-hand side is an ongoing and increasing list of the coping strategies, or what we call skills, the methods that the client has to specifically alter their pain pathway in favor of return to function. So in the body of the care plan, we had always on every treatment, we looked at their present status and their progress to date to remind the client how much progress they had in anything from return to function, but also in decreasing post-procedural soreness, or even soreness to the actual points being done. So we would look at the responses to Gunn IMS with range of motion, reports of pain, reports of function, and of course reports of quality of life. And we looked at the response to the pain programs in a very similar way, but we added phases of change, which just describes kind of mentally where a person is with respect to listening to the advice you're giving. We looked at signs of catastrophization. We of course wanted that to decrease. Rumination and magnification, we always wanted those to decrease. And the overriding thing that we look at within modern pain science is how each individual stimulus affects the client's fear response. Fear is considered the fuel of chronic pain, and so we always wanted that fear to be diminished. We did that through the lessons of the 2 treatment plans for chronic pain that we looked at above, and was added to by adding Gunn IMS at the appropriate time. So the final treatment leading to autonomy. As we went through her treatment program, we saw that her status included engagement in all of her activities of daily living. She did have residual pain, but had put it in its place and it was no longer controlling her. She voiced self-confidence and self-efficacy. She knew the path forward and she knew it would continue. And she demonstrated a working knowledge of that path forward presented within the PME program and the activity choices that she had gained out of her 50-10 sheet. She also showed an appropriate use of that 50-10 rule when her symptom progression got above the green line that was shown on her symptom progression sheet. The things that had resolved or reconciled were her fear over this pain, her concept of hurt versus harm, and its contribution to her lack of function or disability. Her motivation to be personally engaged had got up like tenfold, and she had regained pretty much all of her lost functions to some capacity, and she had observed that it was increasing. And of course, she started participating with her life, with her family, and also within her social circle. So tying it all together, our objective was to present a treatment option that seamlessly blended 3 different models, all within one linear treatment plan. And the different models were classic physio, the IMS portion of the physio, and the biopsychosocial model. And there's actually a couple other things at play as well. There was, of course, the diagnostic blocks with the potential for that pending neurotomy procedure. So this was done by starting with pain education, having a coordinated care plan that was understood both by the interventional radiologist and the physiotherapist. We utilized Gunn IMS to access those peripheral nociceptive inputs that participate in informing the brain as to what possible pain should be felt. And we used a graduated return to activity within a clearly communicated framework that the client was able to understand. And this was all done while monitoring the client's response to interventions to balance the risk of adverse reactions to the benefits of each intervention. So Gunn IMS was used to desensitize the nervous system, leading to the activity once the person was capable of doing that activity without flaring their symptoms. That's what everybody that does Gunn IMS knows and should automatically understand. So that classic model is Gunn IMS desensitizes and allows regular rehabilitative exercises to occur. I'm simply adding into this kind of this concept of modern pain science, which is a step that complements Gunn IMS in working on nervous system hypersensitivity, which Dr. Gunn has always called supersensitivity. I believe them to be the same. And all we're doing is taking the most hypersensitive clients that sometimes would be adversely impacted by IMS because the pain of procedure was too high, and allowing them a little bit of a conceptual framework with which to place their symptoms so that their over hypersensitive nervous system has diminished to the point where getting some needling therapy won't bother them. We started with this gal at I think 2 to 4 points. We ended up at the highest number of approximately 24 points. And by the end of the IMS component of her care, we're back down again to approximately 4 to 8 points. At that time, we were ramping up her exercise and return to function. So talking once again about that subtitle, Treating the Periphery as Old School. Well, in using this case study, I would say the answer to that question is no. Treating the periphery is not old school. The mistake made on his slide was in drawing an artificial boundary, which could be interpreted as opposing sides of a conflict between the peripheral nervous system and the central nervous system. We simply have one client. We additionally have a multitude of options with which to treat this client. The biopsychosocial model, or what I've called modern pain science, asks us to blend all 3 for the betterment of the client. So think of it this way. Science seeks to understand each problem by dissecting it into the complex problem into bite-sized parts. We do everything we can to understand the structure and the function of these individual pieces when we treat a client. In this case, this is the nervous system. But our final part has to be putting back all of these individual pieces together into a functioning unit, which is why I bring our attention always to the client. The client is our unified single-piece functional unit. So applied in this case, we have a peripheral nervous system, and we have tissues, and we have the central nervous system. We have many individual parts. By using modern pain science terms and relationships within this biopsychosocial model, as an adjunct to Gunn IMS, we treat the entire nervous system instead of just the central or just the peripheral system. And I'd like to comment that in closing, when we look at all of these individual pieces together as a whole, it makes more sense to the client. It makes more sense to all the individual practitioners as long as they're kept informed of what the overall plan was. And of course, my hat's off to Dr. Jelena for making that plan and inserting himself as a case manager where there are so many people acting within this guise of a chronic pain program on a client that those nuances often make it overly complex and very, very often inefficient. So those of us that have taken the Gunn IMS program now understand that what was called in the older literature, which was supersensitivity of the nervous system, we now would call hypersensitivity of the nervous system. And within the kind of modern pain science or in the psychology realm, they would call this hyperarousal. I think that these are distinctly different but comment on the same thing. It is an exaggerated or greater amount of nervous system hypersensitivity that Gunn IMS treats using a kind of assessment paradigm and treatment paradigm using a needle. As I said in the progression of this client, that modern pain science deactivates the hyperarousal, allowing for the application in a more comfortable way of Gunn IMS. The Gunn IMS influences the central nervous system through the peripheral nervous system using the muscles as our focused area when we look at shortened muscle syndrome. And we eventually use these two things to continue to decrease that nervous system hypersensitivity so that we can get them back to function. And so what Pain Made Easy adds to this within that kind of first context, but it follows all the way through, is the use of a bunch of client education sheets that will maintain kind of the fidelity of the education that we have by giving people take-home sheets that they can look at in between sessions. Also a part of it, as you've seen, is that each of these sheets are modifiable to match the client more precisely. So what I list as a typical symptom progression can be modified for the client through our blank symptom progression to make sure that any signs and symptoms that they have are appropriately placed above or below the green line, meaning that the client has a very specific method of identifying their symptoms so that they're not just using kind of a cookie cutter textbook kind of mechanism. They're using something that's very, very client-centered. That is the case with all of the Pain Made Easy sheets. We can use the standard sheet to get across the educational component, and then we can modify the message to precisely meet the client's needs. And I think in doing that, you'll find that your Gunn IMS is more effective, but also more easily received by the client. We like to think that we're going to give this needle and it's going to affect C4, C5, and this is going to be great, but we have to remember that there's a person on the other side of that needle who has a hypersensitive nervous system. If you were to do one treatment like I did in my case presentation, or 2 or 3 treatments, educating the person about pain, about what it is and what it isn't, you would notice that there would be a general decrease in the sensitivity of the nervous system, making the application of Gunn IMS more comfortable. The one repeated thing I hear from my clients all the time is, I've had needling and I hate needling, but I'm coming because somebody told me to come to you. What I say to them is that what you're going to probably see within my application of the needling is that it's actually not uncomfortable, it's not considered a form of torture, and that you're probably going to notice a lot more treatment effect because we're also using these other tools, the Pain Made Easy sheets, to govern how we get a person away from thinking about pain and into thinking about function as a prelude to those other both peripherally and centrally effective treatments. So in closing, I think it's appropriate to thank you, Dr. Gunn, because again, what you have done is probably 30 to 40 years in advance. You have led the way by making people see that there was a useful way of observing peripheral tissues from a nervous system perspective. Way back in your earliest documented articles in 1973 and 1976, you made reference to the entirety of the nervous system and that Dr. Gunn was a peripherally applied treatment, that Gunn IMS was a peripherally applied treatment that acted on the nervous system. Where I think some of those studies are misinterpreted is in this idea that we've now broken up the nervous system into peripheral and central, and we've separated it completely from that peripheral tissue. You at all times had always seen this as kind of a unified grouping. You always put the client first, and you provided us kind of an assessment protocol and a treatment tool that would influence the tissue, the peripheral nervous system, and the central nervous system in a very neat and organized way. So like we always say in science, that each of our individual efforts is kind of a culmination of the history of all of the people in the past. I think Dr. Goodman said, standing on the shoulders of giants, and Dr. Gunn, I'm sure you would say that people that you looked up to back when you were coming up and formulating these things would have been Walter Cannon. Walter Cannon was the giant on whose shoulders you stood. And of course, Dr. Gunn, you are the giant on whose shoulders people like myself stand, utilizing all of the important contributions you made in the past to try to continue your work in unifying the nervous system and applying our treatments for the betterment of the client. So again, as always, hats off to you, Dr. Gunn. I appreciate the things that you've added. It's made a tremendous change to my practice, and I'm more than happy to come to talks like this so I can make sure that you're aware of how important your contribution have been. And also thank you to the faculty and staff here at UBC. I think it's very important that we house the Gunn IMS program within an academic institution so we can make sure that the tenets that surround our application of this information maintain very, very high standards. And of course, I've seen myself as an instructor of Gunn IMS how much this program has benefited from your guidance. So thank you very much. And that's it. Thank you.